آه، أتمنى لكم رمضان مبارك وصيام وطاعات مقبولة إن شاء الله في هذا الشهر الفضيل. من دواعي سروري أن أكون معكم اليوم وأقدم محاضرة بسيطة. My topic today is about the biomechanics in prosthetic dental implants. طبعا أنا أقدم هاي المحاضرة من أربيل، هذه مدينة أربيل الجميلة، صورة ليلية. In implants, there is something called surgical driven implant and prosthetic driven implant. Unfortunately, many of our colleagues or many of the dentists doing the dental implant without focusing on the prosthetic part, without thinking about the futural prosthesis that the patient will wear. They are focused on surgical part mostly. So today we are going to show the prosthetic driven implant and the importance of the focusing on the prosthetic part of the dental implant before starting the surgery. First of all, I'm going to show you some of the photos with the failed cases of dental implant. طبعا المحاضرة هي عبارة عن كورس. هذا الكورس تقريبا 300 سلايد. أنا اختاريت من عندها تقريبا 60 سلايد لهذه المحاضرة اليوم. أحاول أركز بها على البايوميكانكس. المحاضرة أو الكورس is in English، بس راح أحاول أسوي ميكسينج between the Arabic and English، والعربي راح يكون ميكس عراقي على مصري. المهم أحاول إن شاء الله أكون أوصل المعلومة بصورة صحيحة تستفيدون من عندها، وإن شاء الله أكون خفيف الظل معكم. هنا بعض الحالات لكيسات تعتبر failure cases from the restorative, prosthetic and aesthetic point of view. أحيانا قد تكون هذه بعض الحالات من ناحية السيرجيكال periodontal succeeded. يعني ممكن يكون الأوسيو integration is good, distance, bone quality, distance between implant and natural teeth, bone quantity, everything is good. But from the restorative point of view, aesthetic point of view, it's a failure cases, just like this case, for example. Now, if we have such a case, how we can restore, how we can put our prosthesis. This is another case. How can we make our impression? طب الجسر كيف راح يتثبت؟ طبعا هنا المشكلة أكيد واضحة إنه هي الباراليزم والانجوليشن of the implant itself. طبعا إنه ممكن شخص يقول إنه البون direction, bone quantity, bone quality in somewhere leading the implantologist to put the implant in this direction. هذا عذر غير مقبول. اكو طرق اخرى حتى نحصل بيها as much parallel implants as we can. هذه واحدة من الحالات. We can face such a case, for example. Now, if the implantologist have a pure surgical mind of view, for example, surgical mind and surgical point of view, and if the implantologist just focus on the surgical and periodontal part, immediately he will go to make a radiograph, he will make a CBCT to check the bone quality, bone quantity, to think about where to put the implant, how many implants to put. But we must think about the prosthetic part, where we are going to put our bridge. Look at the distance, inter-arch space or inter-ridge space. It's very little space. It's not enough to make a bridge. So we have to make our analysis. We have to make what we call it a reverse treatment plan. We have to make a study model, for example, for this case. And then we have to study the case by photographs, by cast on articulator, and then to check the cephalometric, to check the radiograph, the OPG, the CBCT, to see the amount of the bone, the root configuration for the opposing teeth, for example, here. I have to look for some solution for this case. How to increase the space between the upper teeth and the lower ridge to facilitate the bridge insertion in future. So many solutions for such a case. One can say, for example, we can make an orthodontic intrusion of the upper left posterior teeth. By orthodontic intrusion, he can elevate the upper posterior teeth to get a space with the lower ridge. Some can say we can make, for example, crowning by making a crown lengthening, cutting the soft tissue, removing the bone, and then crowning of the upper posterior teeth. And maybe we will need an intentional root canal treatment for these teeth. For example, this is another solution. So here, after making this cast and diagnostic cast, and we're making the our study for this case and making the WhatsApp, then the treatment plan for this case is by crowning of the upper teeth, cutting too much from the occlusal surface, making crown lengthening gingivally or apically to provide more space with the lower ridge to make the dental implant. So this is one of the cases that we might face during doing the dental implant. This is not my case. This is from a textbook. I just want to show you that the idea is that we have to think about the prosthesis before starting our surgical part. Of course, dental implant is not new. It's a developed now. طبعا هو علم حديث. قدامكم هاي الصورة أمامكم نقدر نشوف بها إنه الفراعنة فكروا بالدنتال امبلانت. بهاي الصورة تلقاهم استخدموا الشيل، يعني قشور الأصداف البحرية حتى يسوون دنتال امبلانت بالانتيريور اريا. فور اكزامبل هذه وحدة من المتحجرات الفرعونية. هي فكرة قديمة لكنها متطورة اليوم. عودة للموضوع. So clinical literature reports an implant success might reach to 97%. That's right. And that depends on the location in the arch and the bone density. And the implants are successful, but there can be significant difference between the aesthetic success and the functional success. Maybe the case functionally it's succeeded, but from the aesthetic and restorative point of view, we can consider it as a failure case. So when the case failed restoratively, aesthetically, the result will be catastrophic. يعني النتائج ستكون كارثية من الناحية الجمالية. If we fail to plan, that means we are planning to fail. So a treatment plan is very important, and prosthetic part is very important to be put in our consideration before starting our surgical part. Before going to talk about the biomechanics, about the occlusal consideration in implant dentistry, we have to make a short review about the types of the prosthodontic restorations. As you know, we have two types of prostheses regarding the final bridge or final crown, final prosthesis. Either it is cementable type or it is a screw retained type. Cementable type means that the abutment is connected to the abutment here is connected to our fixture, and then the crown will be cemented over this abutment, just like the cementation of the conventional crown over a tooth. So this is a cementable prosthesis. Screw retained, that means the crown or the bridge is connected to the abutment as a one unit inserted over our dental implant fixture, and then the screw gets inside this crown or this bridge to be or to retain the prosthesis over the fixture. So this is a screw retained prosthesis. As you see here, there is a hole that the retained screw will get inside and attaching our prosthesis to our fixture. Then we can cover the head of the screw by any material. We can cover it by a Teflon, we can cover it by wax, we can cover it by TF, and then we can fill this cavity by a restoration. And also we have, for the completely edentulous patient, we have an overdenture, um, like a bar designs. Here we have a different designs of the bars that the complete denture could be retained over our fixtures by the use of attachment, different types of attachment, either to use a bar or bar over 2 implants or bar over 4 implants. We can use a hybrid denture, can use an overdenture. So we can use a locator, for example, or a ball and socket attachment, different designs of attachment. So here also a locator attachment for a complete denture. A locator attachment for a coupled chromium removable partial denture posteriorly. So different types of prostheses we can use over our dental implant. Generally, and according to mesh, there are different classifications for the prosthetic implant or the types of the prosthesis over the implant. Here, according to Carl E. Mesh, he classified the prosthetic parts over the dental implants into 5 types. Type number 1, we call it FP1. FP1 means a fixed prosthesis replaces only the crown, which looks like the natural tooth. So it's only a crown over the abutment or over our dental implant. Type number 2, which is FP2, which is a fixed prosthesis, crown or bridge, which will replace the crown, the missing crown, and a part of the root. Here, when we have, for example, a bone resorption, tooth extracted for a long time, and there is a recession of the soft tissue and bone resorption, here we have to replace the crown and part of the root, for example. Number 3, FP3, which is a fixed prosthesis, replaces the missing crown, part of the root, and part of the edentulous side. For example, if we have severe resorption and the interrigid space is too much, here we have to substitute or to replace the missing tooth, missing part of the root, and part of the residual ridge. And mostly here in type 3, they use a pink ceramic to replace the missing or the vertical missing of the height of the residual ridge. Type 4, which is a removable prosthesis. So type 1, 2, 3 is a fixed prosthesis. Type 4 is a removable prosthesis. It is an overdenture, but it's completely supported by a dental implant. So it's a superstructure. We can use it over by the use of the bar, for example. We can connect a bar over our implants, and then the denture will be connected or attached to this bar. So type 4 is a removable prosthesis completely supported by our dental implant. Type 5, RP5. It's a removable prosthesis, or it's an overdenture, partially supported by dental implant and partially supported by residual ridge. For example, we can use an implant just in the anterior area, especially in the lower arch, and then the posterior area will be supported by the residual ridge, the soft tissue, and the underlying bone. So it's a 5 types of prosthesis could be used in the dental implant. حتى نفهم ال reverse treatment planning. As I said, it's very important. We have to answer two fundamental questions. Question number one, what is the most suitable prosthesis؟ لازم الامبلانتولوجيست يسأل نفسه شو هو نوع البروستيسيس اللي انا راح اعمله بالمستقبل. So the implantologist has to ask himself what type of prosthesis. Is it fixed? Is it crown? Is it a bridge? Is it cantilever or not? Is it an overdenture? Uh, type of the attachment? And then question number two, where is the optimal implant position to support my prosthesis? So question number one, what is the most suitable prosthesis? Question number two, where to put my implant to be in its optimum position to support my prosthesis. So I have to ask myself these two questions and to understand the answering very well before starting my treatment. So it's a part of the reverse treatment planning. And these questions will lead us to something we call 3D restorative driven. 3D restorative driven means where to put my dental implant inside the bone to support my prosthesis. What's the dimensions? Three dimensions of my fixture insertion inside the bone to support my prosthesis. What is these three dimensions? Dimension number one, it's a mesiodistal insertion or drilling of my prosthesis. Dimension number two, which is a coronoapical, it's a vertical placement of my fixture. How much to go inside the bone and where to stop, where to put the head of my dental implant regarding the crystal bone, regarding the level of the adjacent teeth, the zenith points of the adjacent teeth, and the cemento enamel junction of the adjacent teeth. So this is dimension number two, which is the coronoapical dimension. And the third dimension is the bucco-palatal. Where to put my implant, how much I must leave bone buccally, how much to go palatally, what's the relation of my implant with the adjacent structures. So this is called 3D implant positioning. Here you show some photos about the mesiodistal angulation and mesiodistal positioning of my fixtures. As you know, the distance between the implant and the adjacent natural root minimally must be 1.5 millimeter. More is better. This is the minimum. And the distance between two implants minimally must be 3 millimeter. And here I'm going to show you some mistakes that some implantologists did regarding the mesiodistal angulation. For example, here you see these two implants are parallel, but this one is not parallel to them. So how to solve this problem? How to make impression? How to fabricate a bridge? How to cement? How to insert? And here you can see parallelism is very poor. So some can say I have to ignore one of these. For example, here we are ignoring the middle one, and we modify the abutment of the other one just to get some parallelism between the first and the third implant. The others can say we will leave the first one and I'm going to use the second and the third one. But here the bridge will have a cantilever, and later you will see the side effects of the cantilever prosthesis over the dental implant. So from the beginning, we have to think about the prosthesis, about the bridge, before inserting such an ugly positioning of our fixtures, our dental implant. So avoid overcrowding of the dental implant here. It will affect the inter-implant papillae between the implant and between the implant and the adjacent tooth. As you see here, it's a crowding in the insertion. The distance between the two fixtures is less than 3 millimeters. So avoid the mesiodistal crowding of the fixture. Another case here, because of the poor treatment plan, it's overcrowding of the fixtures inside the bone, less than 1.5 millimeter with the adjacent root, leading to the hit of the root surface, leading to the, root resorption, external root resorption here, periapical lesion, and the amount of the bone between the fixtures is so much less than acceptable. And again, a problem regarding the aesthetic and restorative point. So always we have to look about the optimum positioning regarding the mesiodistal. We have to measure the mesiodistal distance between the adjacent natural roots. And we try always to put our fixture in the middle, with the equal amount of bone mesially and distally. So here, this is the optimum position, but the implantologist put it more mesial. If we did a mistake in the mesiodistal placement of our fixture, this will lead to cantilever, or what we call it occlusal offset. And as I said later, I will explain the problem of the cantilever with the use of the dental implant. So here we have a problem. It's too much wide crown over a narrow implant, positioned too much distally, and we have too much space with the mesial adjacent tooth. Why? Because the implantologist didn't think about the prosthesis when he put such a fixture. Another case here, you can see the dentist here or the implantologist didn't make a wax up, didn't think about where to put the dental implant mesiodistally. And now the result that the implant is in a position which is in between the crowns anteriorly. So there is no benefit from this implant. From the beginning, I have to know where to put my prosthesis, where to put my crowns, and my drilling must be in the center of that futural crown. And the result that this dentist is was removing this fixture. يعني خلاص تعب المريض على الفاضي بدون اي استفاده. حط الامبلانت في موقع غلط، اجى يعمل بروستيسيس، لقى الامبلانت بدون فائده. قام شال الامبلانت وعمل البريدج. خسرنا الجهد والتعب ومصاريف على البيشنت وننتظر الهيلينج. So from the beginning we have to think about our prosthesis. The other dimension, as I said, the coronoapical, a vertical placement of our implant. So here the idea or the rule said the head of the dental implant, here must be about 3 millimeters from the line that connected the adjacent zenith. You know, the zenith is the most apical part of the crown of the adjacent tooth gingivally. So we draw a line between the zenith of the adjacent teeth, and we try to put our dental implant head about 3 millimeters apical to this. There is another principle said we can put the implant head 2 millimeters away from the line connecting between the cemento-enamel junction of the adjacent teeth. يعني أما تحسب 3 ملم عن الخط الواصل بين الزنت of the adjacent teeth، أو تحسب 2 millimeter from the cemento enamel junction of the adjacent teeth and to stop your drilling. طبعا مع مراعاة الcrystal bone, adjacent bone, and the head of the implant must be with the crest of the bone, and it's better if it is a little bit infracrystal or subcrystal. So 1 millimeter is acceptable. And always you have to think about the vertical placement of the implant fixture. Always think that the root, the natural root, is too much wider and irregular in shape comparing to our fixture. يعني الزرعه تبعتنا الفيكتشر بيكون سلندريكال او تيبرد، يعني دائري، بينما التوث ممكن يكون بيضاوي، ممكن يكون يعني irregular in the shape. هون راح نشوف الكروس section of the natural root and the cross section of the implant itself. طبعا لما يكون الروت اعرض او اكبر من حجم الزرعه تبعتنا، معناه انه علاقه الروت مع الفيوتشر كراون بتكون متناسقه اكثر مما انه احنا الزرعه تبعتنا بتكون صغيره ورفيعه والكراون بيكون لارج كبير، فكلش كثير صعب انه ننتقل من الويدث عرض الزرعه تبعتنا وبنروح على كراون عريض. اوكي، دائما لازم نخلي ببالنا انه we have to create what we call it a running room for gradual widening of the emergence profile occlusally. Okay, in cases of gum recession and horizontal bone resorption راح نواجه مشكلة. Again, we have to draw a line from the zenith of the adjacent teeth and to follow our rule or principle. Okay? If one tooth zenith is higher than the other, the line will be angulated. So don't worry, just draw a line and then you can go in the middle and check 3 millimeters away from the line of the zenith. We can use the periodontal probe to measure the depth of our drilling, the depth of the crystal bone, and also to check the mesiodistal clinical distance between the mesial and distal root and the line between the zenith here and the zenith here, and to know where to stop our implant placement crystal. If we didn't put the implant head in its optimum position inside the bone, the result will be a metal appearing in this area. After putting our prosthesis, the metal will appear in this area. We have to hide our metal regarding the implant and the abutment subgingivally as much as we can for the aesthetic considerations. So if we have insufficient depth positioning of our implant fixture, as I said, it will be too much coronally and the implant might be appeared through the soft tissue or beneath our crown. And also there is a trick, or there is a, let me say, a rule. This rule said regarding the crest of dental implant, if we want the space between adjacent teeth or adjacent implants or an implant adjacent to natural tooth, if we want this space to be filled with the interdental papillae or inter-implant papillae, we have to follow the crystal bone and we have to know where to put my contact area. This principle said if the distance between the contact area of two adjacent crowns and the crest of the bone is about 5 millimeters, that means the space between them the triangular embrasure area will be fully filled by the interdental papillae or interimplant papillae. But if the distance between the contact area and the crest of the bone is more than 5 millimeter till 7 millimeter, that means we are going to lose about about 34% of my dental papillae. يعني راح حصل فقط 56% من الdental papillae. And if the distance between the contact area and the crest of the bone is more than 7 millimeters, that means I'm going to lose my interdental or interimplant papillae completely. And the result will be this ugly black triangle. So I have to put in my consideration the vertical placement of my dental implant and the level of the crestal bone and the position of my contact area between the two adjacent teeth, because this will guide my interdental papillae in the future. Third dimension regarding implant placement is the bucco-palatal or buccolingual positioning. If we put our fixture too much labially or too much buccally without providing enough bone, cortical bone buccally, in the future the result will be this ugly appearance. Here we have a bone resorption and we have a soft tissue recession and the metal display here. So the principle is to centralize our placement of dental implant comparing to the adjacent teeth. We have to draw this curvature line or curved line between or touching the labial surface of the adjacent teeth. We have to go about 1 to 2 millimeter palatal to it. If we put it too much palatally, there will be too much distance to the border of the ridge. And this will lead to a negative profile in future. I will show you what I mean by negative profile. And if we put it too much labially or buccally, there will be no enough bone and not enough soft tissue. And then this will lead to a buccal or labial cortical bone resorption and gum recession and the metal display. So if we put it too much palatal, the result will end in this negative profile. I cannot create my optimum or my nice emergence profile. This is called the negative emergence or negative profile, and this is an unhygienic design of a crown covering the soft tissue here. While if I put it too much labially, the result, as I said, metal display and the bone resorption, gum recession in the future. Again, if we put our fixture in the center, exactly where is the root or slightly palatal or lingual to it, I will get enough bone buccally, enough bone lingually and palatally, good crystal bone, good soft tissue relation, and then the border of my prosthesis and the emergence of profile will be excellent. But if I put my implant too much labially, look at here, a very thin cortical plates in this area, and then there will be resorption and gum recession and metal display. If I put it too much palatal, okay, this is what we call it, a negative profile here, and this is non-hygienic for the soft tissue here in this area, in addition to a very thin bone palatally. So we have to evaluate the case and put a very good treatment plan about where to drill and where to put my fixture, because it's um, uh, harmfully affected our prosthesis in future. من هاي الصور راح نفهم implant placement regarding the bucco-palatal positioning perfect, inshallah. If we extract the tooth and we put our implant exactly in the center of the buccolingual or buccopalatal distance. That means my crown will be directly over my implant, and the long axis of the tooth is parallel to the previous tooth or root is parallel to the long axis of the fixture, and also it's parallel to the long axis of the crown, and that means the force will be vertically transmitted from the crown to my implant, and with the very nice emergency profile in this area with the good quantity of the bone buccally and palatally. So this is perfect. But look at here. If we put my implant a little bit palatally, that means the long axis of the previous root is not parallel to the long axis of the implant. And then the long axis of the crown itself is not parallel to the long axis of the implant. And that will push me to use what? To use an angle abutment. Angle abutment means an oblique or horizontal force in the future. And we will see the effect of this horizontal force, the harmful effect of this horizontal force or lateral force on our implant from the biomechanical point of view. Again, if we put our implant too much labially or buccally, and the long axis is not parallel to the long axis of the root and the crown, again here, that will push me to use an angle abutment. Now I want you to focus on this three images and to see where the implant will be placed. You see? Now without abutment, now with the abutment. Here I can use a straight abutment. So the force will be transmitted vertically and distributed over a very wide area surrounding my dental implant. While here, I have to use an angle abutment to get an optimum positioning of my crown in future. And again here, I'm using an angled abutment to put our crown in its optimum position regarding the restorative and prosthetic aesthetic points of view. So, if we put the dental implant in a position not the optimum one, I have later to modify my prosthesis by using the angled abutment. And as I said, angled abutment means a lateral force with the very dangerous effect of these forces on the bone surrounding my fixture. Now I am going to talk in the occlusal considerations and about the biomechanics. بالحقيقة موضوع البايوميكانكس موضوع كبير، موضوع صعب، لا يمكن نغطيه خلال ساعة أو ساعتين. مثل ما قلت بالبداية إنه هذا الكورس هو كورس يومين أو 3 أيام. أنا أعطيه دائما حتى أغطي البايوميكانكس والocclusal consideration and the prosthetic implant as a whole. راح أحاول أوصل فكرة البايوميكانكس او بعض من افكار البايوميكانكس بالدنتال امبلانت بطريقه بسيطه حتى تكون مفيده للمتلقي ان شاء الله. Biomechanical understanding of the implant dentistry. خلينا نتفق على شيء. مشكلتنا بالامبلانت هو الستريس. اذا انا عندي ستريس كبير على البروستيسس، هذا الستريس راح ينتقل على الفيكستشر ثم ينتقل على البون، العظم المحيط بالزرع. واجبي كامبلانتولوجيست او بروستودونتست انه اقلل هذا الستريس. كيف اقلل هذا الستريس؟ To reduce the amount of stress, as you know in the physics, stress is the force over area. So I have to reduce the force and increase the area, the surface area. By this way, I'm going to decrease the stress. How to reduce the force I will explain later. أنا أحاول أقلل كمية الضغط على الكراون والتي سوف تنتقل إلى الفيكستشر ثم الى العظم. كيف؟ مثلا اعمل الكراون صغير، ما اعمل كراون كبير. لو كان الكراون كبير راح يتلقى فورس كثير عاليه، معناها الستريس راح يكون عالي. بس لما اعمل الدايمنشن مال الكراون تبعي اصغر راح تكون الفورس اقل، بالتالي الستريس اقل. هذا كمثال how to reduce or decrease the force. مثلا الاناتومي of the prosthesis. If I did the cusp angle or steepness of the cusp too much, a very high cusp, a very well anatomic crown, that means the amount of the force, the lateral force will be too much. معنى الفورس كثيره معناها الستريس راح يكون كثير. لهذا احاول اعمل الكراون تبعي باقل اناتومي، وراح نتكلم بعدين عن موضوع الاناتومي اوف ذا كراون بروستيسيس. ايضا موضوع الاريا. how to increase the surface area to decrease the stress. احاول استخدم large implant, wide implant, long implant, too many, increasing the number of the implants. By this way I'm increasing the surface area that will receive the force. كل ما يكون عدد الامبلانت اكبر، حجم الامبلانت اكبر، راح تتوزع الفورس على مساحه اكبر، بالتالي الستريس يكون اقل. اذا واجبي كامبلانتولوجيست بالبايوميكانكس انه انا اقلل الفورس، ازيد الاريا. هذا هو البرنسبل. لما تكون عندي الفورس فيرتيكال معناه راح تنتقل للامبلانت وراح تتوزع على مساحه كبيره من العظم حول الزرعه، حول الامبلانت. بينما لما تكون الفورس لاترال جانبيه، هوريزونتال افقيه او اوبليك، معناه انه هذه الفورس ما راح تكون compressible فورس، راح تتحول الى shearing فورس والى tensile فورس or tension فورس، وراح تتركز بهالمنطقه كريستالي وايضا بهالمنطقه ابيكالي. معناه كميه الفورس كبيره والسيرفيس اريا، الاريا راح تكون قليله اللي راح تتحمل هذا الفورس، معناه الستريس راح يكون كثير عالي. اوكي، وهنا راح ينخلق عندي اللي احنا نسميه bending moment، وهذه مشكله كبيره راح يولد بالمستقبل بون ريزوربشن بهالمنطقه واحتمال بون ريزوربشن بهالمنطقه. لهذا انا دائما ابحث عن القوه العموديه، واحاول اتجنب بالبروستاتيك امبلانت اي قوه جانبيه او افقيه او مائله. من وين راح تجي هذه القوه الجانبيه او القوه المائله او القوه الافقيه؟ اذا كان عندي الامبلانت in its optimum position والcrown in its optimum position, but during masticatory or during masticatory force sometimes apply a lateral force on the crown. هذا صار عندي قوة مائلة، احتمال الماستيكاتوري فورس أو mandibular movement during mastication. هذا سبب. السبب الثاني لللاترال فورس لما يكون استخدم angled abutment، لما تكون في زاوية بين الامبلانت وبين الاباتمنت، هذه الزاوية راح تولد lateral force على الامبلانت فيكتشر. هذا احتمال ثاني. الاحتمال الثالث لما يكون عندي كسب كثير عالية والفورسة تكون ديب وهاي كسب، هذه الزاوية تبع الكسب راح تولد lateral force على الامبلانت itself. إذا عندي كثير عوامل ممكن تخلق lateral forces. أحاول أشتغل بالبايوميكانكس، أحاول أشتغل على هاي العوامل حتى أقلل هذا الفورس، وأحاول أقلل اللاترال فورسز وأقلل الستريس. لازم نفهم انه الامبلانت مش زي السن. الامبلانت از نوت ا توث. بالامبلانت تعرفوا بالتوث ستراكشر عندي البريودونتال ليجامنت وعندنا الفيسيو الاستيسيتي اوف ذا بون، يعني اندر ذا فورس، تحت الضغط، تحت القوه، ممكن السن يتحرك بالعظم، يتحرك حتى ممكن تصل الى 28 مايكرون بوجود البريودونتال ليجامنت والفيسيو الاستيسيتي اوف ذا بون. بينما بالامبلانت بالزرعه يكون الالتحام مباشر مع العظم وما عندنا البريودونتال ليجامنت معناه ما عندي هذه الحركة. ماكسيمم موفمنت ممكن توصل إلى 5 مايكرون، يعني 0.005 مليمتر. It's about nothing. لأنه ما عندي الكوشنج أو ستريس بريكر أو الكوشنج إفكت أو الشوك absorption of the periodontal ligament. معناها الإمبلانت is not like the tooth. أيضا ممكن يكون عندي lateral under the occlusal force there will be lateral movement. lateral movement, for example buccal movement of the teeth. وبهذا الرسم تشوفون حجم أو كمية الموفمنت بالمايكرون buccally from the central to the upper seven. And we have to understand the anatomy of the arch, amount of the bone, positioning of the root, to know how the natural root moves and how our fixture will be attached and its relation to the adjacent bone. أحيانا تحت الضغط العالي والقوة الهائلة من الإطباق بيصير عندي هاي الحالة اللي هي احنا نسميها abfraction، إنه detachment of the enamel layer in this notch like appearance gingivally. هذا في أحسن الحالات، حتى السن ما ينكسر بيصير عندك هاي الحالة بالناتشورال تيث. بالإمبلانت يا أما راح يصير عندك chipping أو fracture بالبروستيسيس، أو الكارثة إنه الفورس كلها يكون بها ترانسميشن للفيكستشر وبعدين بتروح على البون. هاي مشكلة كبيرة. طبعا لو كان عندي premature contact نحن نسميها الهاي سبوت، premature contact in the occlusion، هذا راح يسبب لنا ممكن crystal bone resorption، وممكن أن يؤدي إذا كان عندي early loading ممكن يؤدي إلى fibro integration بدل ما يصير عندي osseo integration. لهذا لازم نتجنب تماما ال premature occlusal contact. لازم نفهم الاوكلوجن، لازم نفهم الويلسون كيرف، لازم نفهم the curve of speed during fabrication of our prosthesis. بسبب ضيق الوقت ما اقدر انه افصل بالموضوع اكثر لانه الوقت راح يضايقنا. ممكن على المستقبل ان شاء الله نسوي محاضره اخرى نحكي بها على الاوكلوجال كونسيدريشنز بالتفصيل اكثر. نقطة مهمة كثير، الفورس دايركشن. هنا راح نتكلم على التأثير السيء لللاترال فورس أو الهوريزونتال فورس. لو كان عندي فورس قيمتها 100 نيوتن، 100 نيوتن applied on a prosthesis attached to the dental implant vertically, if this force applied vertically، وما عندي angulation بالplacement of fixture، ما عندي angle abutment، هذا راح ينتج انه هاي الفورس completely will be transmitted vertically as a vertical component، يعني راح تكون compressible bone. هنا احب انطي معلومه، العظم البون can withstand the compressible force very easily, can withstand the compressible force for a limit, but cannot withstand the shearing and the tension force اللي راح يسببها اللاترال فورسز. لهذا احاول الفورس ماستيكاتوري فورس انه كلها تكون باتجاه الفيرتيكالي، باتجاه الكومبريشن او الكومبريسبل افكت اون ذا بون، لانه ما راح يكون بها سايد افكتس على البون. فلو كانت الفورس عموديه ما بيها اي انجوليشن، معناه راح تكون only vertical compressible force, no shearing force, no tension force, no any horizontal component to my force. Okay. If there is angulation about 15 degree between the amount of the force and the direction of my dental implant. يعني amount of force and the implant placement. If there is an angle between them about 15 degree, what will happen? There will be vertical and horizontal components. يعني القوة المائلة تقسم إلى مركبات القوى، قوى عمودية وقوى أفقية. المشكلة هي بالقوى الأفقية. فراح يكون عندي ال 100 نيوتن راح تصير تقريبا 96.9 نيوتن vertical force، احنا نسميها axial force component, while the other is about 25.9, about 26 newton, which is a buccal force component، يعني القوة الأفقية horizontal component. That means here I have a horizontal component. Why? Because there is angulation 15 degree. If I have more angulation, if it is 30-degree angulation, what will happen? The horizontal component will be more. It will reach to about 50 newton. 50 newton horizontal force or horizontal component. It's a big problem. المفاجأة انه القوة الأصلية هي 100 نيوتن. لما نجمع الفيرتيكال والهوريزونتال كومبوننت فورس، يعني لما نجمع ال 97 مع ال 26 راح يطلع عندنا حجم القوة هنا كثير أكثر من حجم القوة الأصلية. يعني 97 زائدا 26 تقريبا راح يصير عندي تقريبا 123 124 نيوتن. 124 while the original force is 100 newton. Why? Because it's oblique force with a 15 degree. And when the degree increased till 30, for example, the amount, the total or the sum of the force will be, here we have about 86 plus 50, 86 vertical component, 50 horizontal component, معنى 136. That means too much more than the original force. And we call this a force magnifiers. So the angulation of our force over our fixture will lead to magnification of the force. So always we try to avoid the force magnification, the force magnifiers. How? مرة ثانية نقول اتجنب اللاترال فورس، اتجنب الانجل abutment، اتجنب الهاي cusp in my prosthesis. And here we can see in this diagram, when the angulation increase, the amount of force increased. This is a problem. And here you can see that the bone can withstand the compressible force without any problem, while there is a problem with the tension and the shear forcing. Now, maybe one dentist can ask, Doctor, how you measure these numbers? From where you bring this 96.9 and 25.9? How you got these numbers? The answer for this question is here. Let's say this is my dental implant. And let's say I have this oblique force with the 12-degree angulation over a long axis of my implant. It's a 12-degree angulation. So 12-degree angulation lead to a vertical component and horizontal component. How to measure the amount of this vertical force and the horizontal force? How to measure them? How to get the numbers? It's very simple. Here you can see in this equation, the vertical component is the amount of force multiplied by the cosine of the angle. يعني الفيرتيكال كومبوننت هي حجم الفورس مضروب في جيب تمام الزاويه، راح يطلع عندي رقم. هذا يمثل الفيرتيكال كومبوننت فورس. الهوريزونتال فورس راح يكون amount of force multiply by the sine of the angle. يعني كمية الفورس 100 نيوتن مضروب في جيب الزاوية 12 راح يطلع لي رقم. هذا الرقم راح يمثل مركبة القوة الأفقية. By this way, just to know the amount of the force and the angulation of the force, we can get the vertical and horizontal amount of the force over my dental implant. I hope you get the idea. So I'm sorry about the time. This is another explanation about the amount of the force and the effect of the lateral forces over the dental implant and the surrounding bone. And one of the problems regarding the biomechanics is the use of cantilever bridge or cantilever prosthesis over the implant. And here we can see if, for example, if we use this cantilever over two implants, what will happen regarding the force? Don't forget, my concept is to decrease the force. If I use a cantilever, what will happen to the force? Now, let's say I have two implants. I use this a 5 unit bridge over these two implants. Let's say the distance between the two prostheses here is a 10 millimeter, and the distance from the most distal part of the bridge and the last abutment here is a 20. Let's say I have a force 25 pounds over this distal pontic. What will happen? Look at here. What will happen? The force will be 50 pounds on the first implant in an opposite direction. In an opposite direction. So the force here is from occlusal to gingival, while here on the first abutment will be from gingival to occlusal. It says double. Why? Because the distance here is a double of this distance. It's a 50 pounds. And the bigger problem is not only here. Bigger problem is here. The this the second abutment will receive the total amount of the force. This is 25 and this 50. So there will be a bending moment about 75 pounds مجموع ال 25 وال 50 حول هذا الامبلانت المسكين. هذا معناه ايش؟ بالمستقبل راح يكون عندي horizontal force surrounding this implant and this implant وبالتالي crystal bone resorption definitely, and then peri-implantitis and the failure of these two implants. This is the problem and the effect of the use of cantilever over the dental implant. And again here, you can see if we use a bridge over an implant, one or two or more, there will be 6 axes of rotation, many axes of rotation for this bridge. Try to displace, try to bend our implant, try to displace our bridge or distort it. So it's big dangerous to use a cantilever, too much cantilever distally or medially over a few number of dental implants to avoid these so many kinds of an axis of rotations. Again, regarding the biomechanics, we always try to put our force, as I said, vertically, and also we try to put our force centrally. The force with the opposing teeth or tooth must be directed vertically over the abutment. The contact area must be here, not here. This is wrong. This will lead to what? To a lateral force. So always try to put the contact area with the opposing in the center of your abutment. And you have to tell your technician to do that for you. And again, to decrease the amount of force, try to use a narrower prosthesis as you can. If you are using a very wide bacolingual dimension of your prosthesis, that means too much force and too much stress. It's another problem. And the problem will lead to an oblique force, might lead to the defect in the prosthesis, chipping or fracture of the prosthesis, or to a bone resorption buccally. Sorry. As I said, always try to put the contact in the center. Even if you have two opposing implants, try to put the contact in the center of each one, whatever the relation of the crowns was. So this is more buccally to this, but the contact is still in the center for both of them. If you are using a cementable type of prosthesis, the red spot represent the preferable points of contact with the opposite. النقاط المفضلة للإطباق مع الفك المقابل أو الأسنان المقابلة. إذا أنت بتستخدم cementable type، تستخدم سمنت بالكراون أو بالبريدج، خلي الكونتاكت بوينت تكون بالسنتر in the center of the prosthesis over the center of the abutment. Here. So the red spots is the preferable point of contact. The blue spots, mesial and distal, is the second preferable area for the contact with the opposing. Now I want you to focus. There is no spot distally here. This is the most distal abutment. Abutment or prosthesis, and there is no mesial contact here. Why? Why? Because they are splinted to each other. So there will be no any occlusal offset or cantilever if we put the contact in the mesial and distal marginal ridge. But here it will act as a cantilever, and here it will act as a cantilever or occlusal offset. So the red spot in the center is the first preferable point. The second blue point is the second preferable point, mesially and distally. Avoid the most mesial and the most distal one. If you are using screw retained prosthesis, you have to avoid the contact with the opposing in the center, over the hole, over the restoration that you put to close the gap. So here it's preferable just to put the contact in the mesial and distal marginal ridge, and you have to avoid the center of the crowns. This is another rule in the biomechanics regarding the or related to the opposing contact. So the principle is to decrease the force, increase the surface area to decrease the stress. How to decrease the force? We can play with the design. And that depends on the bone quality, and we have to extend the healing time to get better osseointegration. We have to increase the implant number to increase the area that will receive the force, and we have to increase the diameter of the implant, the length of the implant to increase the surface area, and also we can modify or play with the surface, the implant surface, and surface treatment of the dental implant to enhance better osseointegration. So the more implant, the larger implant, the more surface area to receive the force and to decrease the stress. Here we have the most recommended placement of the implants in the anterior area. You see, the most recommended area of implant. Of course, this diagrams or photos according to Carl Emisch. And this is the most posterior preferable area and recommendations to put your dental implant regarding the number and the position or the location, the placement. And each implantologist, every implantologist must understand perfectly the anatomy of the natural teeth itself before starting the dental implant, the roots, the sizes, the width of the crown, the natural crown itself. Why? Because this is very helpful to create a very well emergency profile to receive the final prosthesis. Another recommendation, according to Carl Emisch, a wide implant in this color, blue one, the standard or regular diameter in this, maybe pinkish or purple, and the narrow implant in the yellow. You can see here, the regular implant is used in the upper centrals and premolars area, while the laterals is a critical area of dental implant. Here sometimes we have to use a narrow implant in the upper laterals, while the posterior, the molars, we have to use a wide implant here. Regarding the lower, the four anterior teeth is also, this is a critical area for the dental implant. Sometimes we have to use a narrow implant. In the canine and premolars, a regular implant fixtures, while in the molars is the wide implant. And another point regarding the biomechanics is the splinting of the prosthesis. It's better to splint, not like the natural teeth. For the natural teeth, it's better to separate the crowns in the full mouth rehabilitation. If you have so many abutments, you have to separate between them. But in dental implants, it's better to connect between them, between the implant itself, but not between the implant and the natural tooth, of course. So splinting is recommended sometimes or mostly in the dental implant prosthesis, and sometimes splinting with the adjacent teeth by a wire or by any other thing. For me, I didn't do it, but I found this photo in one textbook. They splint the tooth palatally. Why? Because they use a very narrow implant here because of the critical area. As I said, the upper lateral is a problem always. Here you can see the advantage and the disadvantage and the indications to use a long implant, short implant, wide implant, and a narrow implant. For example, for the long implant, you have to make your drill too much apically inside the bone. For example, there will be too much heat generation because of the poor cooling inside the bone. So this is a disadvantage for the long implant. But as an advantage, there will be too much primary stability. Regarding the indication of the long implant, to make an immediate placement, I mean immediate extraction and placement of the implant, it's better to go post-apical area, so you have to use a long implant. When you have a bone defect, you have to use a long implant, tilted implant, and a poor bone quality. Regarding the short implant, it could be an alternative to a bone grafting. When you have too much horizontal bone loss, for example, you have a sinus and a very short thickness of the bone, little thickness of the bone, you can use a short implant to avoid the bone grafting, for example. So the indication is the limited bone height. But the side effects of the short implant is the poor primary stability. For the wide implant, it can give you good primary stability, good cortical anchorage, good crystal bone contact, stress distribution, and the releasing components. While the problem or disadvantage of the wide implant is the lateral overheating, poor cooling. The indication when you have, as I said, a limited bone height, poor bone quality, and in the molar area, for example, and when you have a patient with a paroxysm, it's better to use a very wide implant because this implant are going to have or to receive a high force. A narrow implant, sometimes you have to use it to avoid the bone grafting vertically, but the problem here is the low mechanical resistance and the indication when you have a small diameter teeth and limited space. Of course, you have to understand the design of the implant itself, whether you want to use immediate loading, you have to think about the design of the dental implant itself, or you are going to use a conventional implant. So you have to understand the implant design because it will affect your biomechanical effect of your final prosthesis. Regarding the occlusal surface, as I said, it's better to use a narrow prosthesis, not a very large occlusal table, very shallow cusp, and Weinberg in 1995 found that increasing the cuspal inclination by 10 degree will increase the load by 30 degree, or sorry, 30%. That means 10 degree increasing of the cusp angulation will lead the amount of the force 30%. The most recommended principle here, not to make it very flat because there will be no efficiency in the cutting and mastication, not too much flat, and not a very high cusp angulation, they prefer to use a 20-degree cusp angulation or steepness for the posterior teeth. And again, the contact with the opposing must be in the center or medially if there is a contact or supplanting with the other implant. We have to avoid the steep cusp angle, the inclined contacts, the cantilevers, the wide occlusal platform, the posterior interference in centric and eccentric, and the excrusions. We have to avoid all these because by avoiding this, you are going to avoid the lateral force, and this will help your biomechanical effects over the prosthesis. And sometimes we can use some attachment and some type of material that will act as a stress breaker and shock absorber to decrease the amount of the force over the dental implant. For example, the PEEK material, consider one of the materials that is suitable to act as a shock absorber and stress breaker. Some blocks, CAD-CAM blocks or ceramic, have some stress breaking effect during fabrication of the prosthesis. This is another advantage of some blocks. And always try to avoid connecting between the implant and the natural tooth because, as I said, natural tooth can move inside the bone for a limit. It's a normal physiological, not a pathological movement, normal physiological movement within the limit of the periodontal ligament and the physioelasticity of the bone. But the fixture cannot move inside the bone, so there will be a cantilever effect of the bridge, and this will end in a bone resorption in the crystal area, and maybe widening for the lamina dura here or a defect in the periodontal ligament here. So try always to avoid connecting between a natural tooth and a dental implant when there is a termination, terminal abutment implant here and terminal abutment natural tooth here. If the terminals are the same type, sometimes there is some permission to use or to connect between them, but the general principle is not to connect. That's all. Thank you. I think I took too much time. Thanks for your listening and thanks for your attention. I appreciate your participation, in my lecture. ان شاء الله ما تكون المحاضره ممله دكتور عبد الرحمن.
لا، محاضره جميله فعلا، استمتعنا والله كلنا، بس في شويه اسئله عايزين بس نجاوب عليهم.
اوكي، خليني بس اخذ ريست واعرض فد وحده بس من الحالات اللي انا اشتغلتها.
خلاص تمام.
يشوفوا المتابعين حالة تمام. او حاجه وبعدين نرجع نتكلم نجاوب الاسئله ان شاء الله. اوكي
جميل.
هنا انا استخدمت الدنتشر سيمي كومبليت دنتشر كترانزيشنال او ك temporary or provisional restoration to create this transitional smile. يعني temporarily to be used for a 6 months until I get a fully osseo integration. So this is a transitional smile. واحب اشوفكم في شيء انه هون هذا الدنتشر انا عملت له لايننج بالتيشو كونديشننج ماتيريال. هاي الماده البيضاء هون، هذه الماده البيضاء هي تيشو كونديشننج ماتيريال تو act as a shock absorber او stress breaker to decrease the force over the ridge and over the bone. فهذه واحده من طرق عمل البروفيجنال ريستوريشن. انا دائما افضل البيك اب تكنيك او الاوبن تري تكنيك بعمل الامبريشن. هنا انا عملت سبلنتنج للامبريشن بوست باستخدام الباتر ريزن. انا ربطت الامبريشن بوست مع بعضها باستخدام الباتر ريزن، وان شاء الله في محاضرات قادمه ممكن نحكي على الامبريشن تكنيك حتى نعرف شنو فائده هذا الشيء. هذه واحدة من الكيسات. طبعا هلا احنا بالوقت الحاضر بنحضر لللور حتى نعمل امبلانت لللور.
تسلم ايدك يا دكتور فعلا.
كمان في كيس اخيره لها علاقه بالبايوميكانكس. احب اشوف الاخوه الزملاء. هذا البيشنت عمره تقريبا 20 سنه، 20 years old male. You see the patient come to my clinic in this situation, and here he has a retained root, but a very well root canal did for this, and no space to do the dental implant, but the amount of space here, central and lateral, is too much. I can't put one abutment here, and I can't do the implant to put two. I don't know what to do for this case. So it's a complicated. Just like this. So what I did a mock-up by the use direct mock-up. I use a composite. I put a composite over the root, and I put some composite even here on the mesial side of the central. I want to see what will happen if I just did crown lengthening and core build-up. If I put just a crown over the lateral, and if I did a layering composite to the adjacent. I want to see the result. This is just mock-up. And I found it's very ugly. It's very large crowns, centrals, very wide, and even I can't close the diastema here, the space. So I decided not to do a single crown over the lateral, I shift my treatment plan. So this is the reverse treatment plan. I start from the prosthetic, then I go to my implant surgery or implant procedure. So I decided to refer him to orthodontist by making orthodontic treatment. He gave me more space. He tried to correct the shifting midline. He gave me more enough space to do the implant. Then I did my implant surgery here after making CBCT and checking the thickness, the amount of the bone. And you see after healing, and this is a provisional restoration. It's a temporary connected by a wire, the retentive wire of the orthodontic treatment palatally. I use it to connect my provisional restoration, a temporary restoration. I'm waiting for a more healing and more stabilization after orthodontic treatment, more stability. Then a core build up for this lateral. And now I'm ready to make the open tray impression for this. And here you see the abutment in place. And this lateral is large enough to receive a crown. And this is the final result for this case. So this is one of my cases in the aesthetic zone. So please don't think immediately about the surgical part or the periodontal part. Try to make a study model, photography, try to study the case from all the points of view, then to put your treatment plan. Here, the orthodontic treatment took about 8 months, and then the implant surgery, waiting after 4 months more for complete osseointegration, and then we did the prosthesis. It takes time, and maybe somewhat costly, but the final result will be perfect, especially he's a very young guy.